Hi, nice to meet you.
Nice meeting you. How are you?
I'm good. How are you doing?
I'm doing well, thank you.
Good. So basically, I wanted to sort of pick your brain a little bit. First of all, the flu encyclopedia was awesome. Um,
Oh, I'm glad you like it. Yeah, it's been getting a lot of hits lately, as you might imagine.
yeah, I'm sure it has. We've gotten a few questions down here about that. Obviously, with everything going on. Uh, so I had a few questions about it.
Hmm.
One of them that I found really interesting is when it came out. So can you tell me like when you started working on it, like how that idea came up?
Yeah, so it actually grew out of a contract we did for the CDC. So the whole story is the center got involved in examining the 1918 influenza pandemic in 2005. So that was the Bush administration was concerned with the possibility of avian influenza, H5N1, which was circulating in wet markets in Southeast Asia.
Hmm.
And it's very deadly. It's not very easily transmissible from poultry to humans, but there were some cases of poultry, small family poultry farmers getting sick, and there were a handful of cases of human transmission to other humans within that family, and it has something like a 30% mortality rate. So it's really high. So they were worried that this could potentially be the next influenza pandemic or respiratory pandemic. So the idea was, what could we do? And so the Defense Department first contacted us, and they wanted to do a study on what we ended up calling provisional escape communities, small places like Gunnison, Colorado, for example, that basically shut down. They closed the entire county to prevent influenza in 1918 from coming into their community. But that doesn't tell you a whole lot, because these are really small communities. Some of them were sub-communities. They were like Princeton University, for example. There was a school for the blind in Western Pennsylvania. So then the CDC came to us and said, look, we know we have the ability to make influenza vaccines, but we have to type the strain. So anytime there's a new strain, like we saw this in 2009, for example, when there's a new strain, they have to isolate the strain, genotype it, come up with a vaccine that matches it, a monovalent or polyvalent vaccine that matches it, and then get distribution. And so ramp it up. And that's going to take at minimum 6 months generally with influenza. What do we do in those 6 months to try and control the spread if we have this massive pandemic? And can we learn any lessons from 1918? So it was out of that we studied the use of these closure orders and gathering bans and school closures, isolation, quarantine, et cetera, in American cities in 1918. That we then published the paper on that, and in fact, those things do work. Those isolation control measures do work. Non-pharmaceutical interventions is what we call them. They lower overall mortality and morbidity, and they flatten the curve. We've all become familiar with that phrase, and we're the ones who developed that phrase, flatten the curve. That came out of our work, in fact.
Oh, wow.
So we published that in JAMA in August of 2007, and we had all of this data, all these historical documents, a lot of newspaper records and other documents. And so we thought, we should make this available to researchers. We went to hundreds and hundreds of archives and spent countless hours in places like National Archives and Library of Congress. So what can we do? And so we partnered with M Publishing, the scholarly publishing office at the University of Michigan, and we scanned all the documents. I wrote all of those city essays on the website. We worked with a web designer, and so we created that influenzaarchive.org website, and we expanded the list of cities. And we had originally in our study had 43 cities because of limitations with data, but we expanded it to 50 when we got to the qualitative side, because we didn't have to have that same data set, that comprehensive data set. And so we added Detroit back into it and a couple other cities that we had some good information on, and then we put the website up. And that was, so we started working on the website that would have been probably late 2007, early 2008, and we launched it in October of 2012.
Yeah. Okay. Yeah. So that was like almost a decade-long project from when it started to like when that came up.
Yeah.
So what is your background like?
I'm a historian. Yeah.
Okay.
So actually, it's interesting. My training is actually in political and diplomatic history.
Okay.
And there's a long story I won't bore you with of how I ended up at the Center for the History of Medicine. But I sort of transitioned into, because of this flu work and some of the research I had done in some of the archives, they asked me to join them at the center. And so I kind of transitioned into a historian of medicine. And so now I've become this expert on 1918 pandemic, when if you had asked me prior to 2005, I would have never guessed that would have been where I ended up, in
Yeah.
2020.
That's how this stuff works sometimes.
Yeah.
That's also really timely for you, given what's going on now. Like you mentioned. So we're in East Tennessee. We're a really small area, but we've started to get people like asking about it. So like a lot of historic sites, back in March, we shut down.
Mm-hmm.
We transitioned to research, doing online work. And one of the first topics that we wanted to look at was this area with the flu, to provide some context. And our starting point was, like you mentioned, there were a lot of closures in 1918. And a lot of people, at least at the start of this, weren't necessarily aware of that, especially in our area. So like with schools and everything shutting down, like we knew for sure already, just based on the research we had just accumulated to the time, that the flu was in the area and that schools shut down. So like we knew specifically, like there was one article that we could find pretty quickly. I think it was like October 17th, 1918, where the schools in our town shut down for 2 weeks. So that started our ball rolling. So we, before libraries shut down too, we did a few archival newspaper researches, and we expanded. So we looked at a few of the area newspapers, and we focused mostly on the fall to start of winter, going into the start of 1919. But it's the same thing. A lot of the same steps that we were taking today were being taken then. So we covered a lot of that. And I've seen a lot of especially places like San Francisco and different places had the mask mandates and things that were put in place. And then even at the time in 1918, there was some negative response to that. So from what I could tell, there weren't anything mask mandates or requirements in our area. Now that might have been, but nothing covered in the press. And not any. So if there wasn't a mandate, there wasn't necessarily a back and forth over it. But did you see that already, when you were putting this stuff together back in 2005, how some of the steps that were taken weren't necessarily universally popular? Could you argue that back then?
Yeah. In fact, I have a forthcoming article in American Journal of Public Health. I don't know when it's going to be published. It's been accepted. So sometime next couple of months, on this issue of pushback in politics, when it comes to public health measures in 1918, and then comparing and contrasting with today. So, the mask orders in particular were the one thing that seemed to really annoy people then as well as today.
Yeah.
And they tended to be, for a couple of reasons, they tended to be implemented out west. They were recommended, generally speaking, nationwide. Most states and United States Public Health Service, as well as the American Red Cross, recommended their use. But it was only out west, with the exception of some places in Indiana. Indianapolis, for example, implemented a mandatory mask order. But generally, it was not something that you found in the eastern half of the country. So we're talking Denver, Seattle, lots of communities in California. Portland, Oregon finally sort of did implement one. It took them 3 tries. And the last ordinance they implemented, they said, well, if the conditions warrant it, again, if we get another spike of cases, it will go into effect. So it was passed, but provisional on another spike of cases. And that by that time, the epidemic was largely over. So it didn't actually go into effect. But yeah, you mentioned San Francisco. That's where we see this anti-mask league. That was the only evidence of an actual sort of formal, organized protest against masks. But there were lots of people who refused to wear them. So all these cities that passed ordinances they passed alongside very hefty fines and threats of arrest for not wearing a mask. And there were people in every city that we studied that had mask orders in place. There were lots of people arrested. There were hundreds in San Francisco, for example. In terms of the other orders, the closure orders, school closures, gathering bans, particularly business closures. And in 1918, it was largely relegated to places of public amusement. So theaters and movie houses in particular, bowling alleys, sometimes cafes and cabarets, dance halls. Those places generally went along, those owners and managers generally went along, at least initially, because the public health idea was that influenza is generally a seasonal malady. It is occasionally an epidemic. It grows to an epidemic. So in 1889, 1890, for example, there was the quote unquote Russian flu. So they had experience with these epidemics, and one fairly recent, within the past few decades. And they thought, the public health officers generally thought, okay, we're going to get a spike of cases. It'll be over quickly. This is just sort of the way these things run. They have to run their course, kind of. They start in the military camps. And so they said, well, we'll probably be fairly safe. Military camps are lots of people in close quarters, et cetera. Then they started getting civilian cases in places like Boston and New York first. And then they realized, okay, it's now spreading to the civilian populations. This is much more serious. And so most public health officers across the nation at the state and local level implemented these closure orders of various things. And generally business owners went along, because if you're a movie theater owner, it's also wartime. So you want to be seen as doing your patriotic duty. And you also realize, well, if there's an influenza epidemic, people aren't going to go to the movies anyway. So let's close things down. They did things like sterilize, ventilate places. And the idea was, if we close things down, maybe we can just get through this in a few weeks and it won't be too bad. In places in the East Coast, because of how rapidly influenza hit, population densities, especially in housing, those epidemics were very steep, lots of deaths, lots of cases, but they were over fairly quickly, within a few weeks. In places in the Midwest and out West, they tended to last a little bit longer. And so that's when you start to see, and in some places in the Southeast, and so you start to see some pushback from theater owners, for example, who are saying, well, you told us this was going to be just a sort of a 2-week thing, and now it's stretching to 3 or 4 weeks. We're losing box office receipts. We have people on payroll who are out of work now. When can we get back to normal? And in some places, like in Atlanta, the mayor said, he sided with the business owners and said, okay, we want to reopen. Asked the Board of Health. The Board of Health said, no, our epidemic here is not over. He overrode them, and along with the city council, just voted to reopen things. In other places, they had, Max Starkloff, for example, in St. Louis, was a very forceful public health officer. There was lots of pushback against the closure orders, and he said, I don't care, we're keeping things closed because this is what's best for public health. So it kind of varied, but there was some pushback. Wasn't as much pushback with school closures, but that did happen in some places.
So how were the school closures? Was it sort of like the same thing? Like it was like a 2-week initial period, or like did it last?
Yeah, it sort of depended on the local context of these epidemics. Then as now, and even more so then, these were handled at the state and local level. So public health in the United States, as we know now, is primarily state and local level. Post New Deal, post Great Depression, I think Americans have a more general sense of that the federal government should intervene in our lives when it comes to big national crises, public health or otherwise. That wasn't the case in 1918. So there really, aside from the United States Public Health Service and the U.S. Surgeon General, there really wasn't, and they only issued a couple circulars and recommendations. It was all public health was at the state and local level. And that's particularly the case for schools, because, the way we run schools in the United States, it's all the local school district level. So there were a couple of cities, and there may have been smaller towns, but we did find that Chicago and New York and New Haven, Connecticut, and I think Bridgeport, Connecticut as well, did not close their schools. Most other places did close schools. And typically when states generally recommended a series of closure orders. Sometimes they mandated them, but they almost always left school closures up to local jurisdictions because of the way the politics of schools work. And most places, of course, even if initially they thought we don't need to close schools. Very quickly, when you start to get cases, you close schools because no one wants to be responsible for sending a kid to school and having that child die. And in 1918, young children weren't generally affected too greatly by the H1N1 strain of influenza in 1918, but high schoolers were. So that when you look at the death toll by age groups, it was that age group sort of 15 to mid 40s that was most impacted. And in fact, it peaked at age 29, 28. That was the group that was most impacted. So, you want to protect high schoolers. So they closed schools. There wasn't too much pushback. And in terms of duration, again, it depended. So in places in the East Coast, it may have just been a few weeks because the epidemics were over, more or less. The worst part, it was over in a few weeks. But in places out West, it may have dragged on for 4 or 5 weeks. And in a lot of places, they opened too early. The epidemics weren't over. They had another spike of cases and they had to reclose. And in particular, they tended to reclose schools. A lot of communities didn't reclose businesses a second time because that was economically and socially unpopular, but they reclosed. A lot of places did. About half the cities we studied reclosed their schools a second time.
Oh, that's really interesting. So one of the things that we couldn't find anything definitive on business closures in our area. If you go, like, we looked at some of the Nashville, like the Nashville Globe, and it seemed like there were more like just community, business, church, school closures in Nashville and that urban area. So we did find, it seemed like the going closure rate was about 2 weeks here. It's like a school was shut down for 2 weeks. So we only had like 1 or 2 like actual like sort of front page articles that was like this school is closing. But so we're pretty rural in some of our areas. So like if you went to like this other community, it would be like sort of an aside, like, oh, this school is now shut down for 2 weeks. So it's hard to like track exactly when it happened, but as you said, that was just local and up to the community. The only sort of pushback that I came across, there was like sort of a commenter that wrote an article with a bunch of different things, and he basically was trying to make the case of we shouldn't close all the schools. We should wait until like there are cases in the school. So that sort of makes it sound like there was at least some community awareness and probably some people within the community that were trying to just sort of preemptively take that 2 week or 3 week step. And it does seem like some of the schools did take like a preventative approach, and then some of the schools would wait. So we kind of tracked it. I guess the most unique closure case we saw, there's a college about 30 minutes from where we're located here, and they apparently had no real cases until like mid-November. And when they had a pretty big article about their closure, but when it hit very quickly, and so they had to shut down, and the community actually had to pick up. So like there were actually people from that college that were like being housed in homes of the rate that it hit.
Yeah.
They also mentioned that there wasn't that much mortality rate when it hit them, at least not at that point when the article was published. But I think that's one of the things that really differentiated this 1918 flu outbreak is, as you mentioned, the age range was not typically the age range that was hit with those things.
Yeah.
We looked at 2 different counties and compiled death record data from October to January. So like really the height of when that hits, and then it starts to sort of taper off and comes back up. And the age for one county, the highest age hit was actually the infant to 5-year-old range. And then the other county, it was sort of that later, like that teenage range to young adult. So, but it seemed like most of the under 5 mortalities were actually like within a year, like year to 2. So pretty vulnerable in that age range. There were quite a bit of the like teenage and young adult through like the 30 age range. So
And with influenza, so the typical influenza death curve by age is a U shape. So you get the very young, like you said, so children generally under 5, and especially 1 to 2, 3-year olds. And then the very old, because those are the groups. So if you're very young, your immune system is not fully developed. And if you're older, your immune system is starting to become naturally compromised. And what happened in 1918 is we saw a W-shaped curve. So you still have those two, age extremes that are impacted, but then you have this spike in the middle of people, sort of the teens to early to mid 40s, and spiking in that late 20s to early 30s.
Yeah, which was especially like you mentioned, World War I plays such a big role. It's like all this stuff is sort of compounded together. So
Right.
we have that age bracket hit with the flu mortalities, coupled with worldwide, not just in the United States, but worldwide, that age range also facing the military deaths on top of it was really like had a huge social shift, but also social impact on people as they were living through it. So
Yeah, absolutely.
But so we put together like this online exhibit that basically just compiled like all the newspaper articles that we came across over the last like 2 or 3 months. We've been rolling out some of these like on our social media and like contextualizing them. So like we're talking about a school closure and contextualizing that, about how into like with this current situation, it's not the first time that we've gone through this, and so we've been rolling that out. So basically, we put together this little online sort of virtual exhibit that you can see all those articles sort of broken down by content, like topics. So like we have a few on school closures, community closures, obituaries, some of the entertainment. So like there were a lot of poems that people wrote about the flu and those sorts of things. So we tried to like break it down by topic and that sort of thing. But one of the things we included was an external link, because this is very regionally focused, obviously.
Mm-hmm.
And that's where I was trying to find like a bunch of really good external links for people to put what we're going through here in East Tennessee, sort of in the broader context. So the CDC timeline of events and about the Boston outbreaks and the military camps being like the hotbed, and then it goes to civilian populations. But that's where I came across this flu encyclopedia. So it really is just a wealth of information.
Yeah, I mean, as I said, it was many years in the making. Lots of people. We had a team of researchers, research assistants gathering that data, and we were abstracting all the documents that we found and scanned. I don't know, I lost track, but it's tens of thousands of pages of documents.
Yeah, it covers a ton of stuff. Is there any plan, like, are you still kind of working on it, or is it just sort of stopped now and like you're just sort of like dealing with people like me who are reaching out about it?
Yeah, every once in a while we'll update it. So we had sort of what we call, version 2.0, where we added some more records that we found, some military records and some other things. So we continually work on it. It's not something that I do every day, but we'll do it sort of once or twice a year. We'll go through, we'll gather up some new documents that we've uncovered. We'll scan them, have them scanned, and we'll sort of add them. So, in terms of the interface hasn't really changed, but the content behind the scenes, the sort of the database content is constantly being updated. One of the challenges we have is that was built on a very old, rather rickety digital platform that when we had it, when it was built, it was already like 20 years old. And it was something that was crafted by the University of Michigan Library back when these sort of digital projects were relatively new, and there wasn't anything sort of off the shelf that, content management systems that you could turn to. And of course, since then, you have, Drupal and WordPress and umpteen other things that have come out, and new metadata programs and schemes. So they are working on, the University of Michigan Library has, and publishing have been working on transitioning all of their existing intellectual properties, including ours, to this new platform they have. but ours, the way ours works is rather unique in their sort of ecosystem. And so we're not sure if, when, and how that transition is going to be made. So, you know, it's clunky. You know, I think reading the essays is fine. That works very well. You know, that's sort of straightforward web design. But calling up some of the documents, especially when they're multi-page, you know, and you can't just scroll through them nicely. You have to hit next and it has to reload. That's very clunky. And so we're hoping that in sometime in the next couple of years, that will be updated and it'll be a much smoother user
Yeah.
interface.
Well, you know, it's really, you know, stuff like that's been around for a while, because you know, like you said, that was uploaded almost a decade at this point. So was updated with like state-of-the-art web design that's still almost about 8 years old. So that brings up a whole other discussion of updating like stuff that was made like 5-10 years ago. And
Right.
but if you go and look at you know, things like the, you know, Gutenberg project and like all these like sort of initial like early 2000 primary source documentation stuff, they're still a little bit clunky, but you can navigate them and get the resources. So I think
It's still, yeah, the documents are still there and accessible.
and that's all that's really the most important thing that we used. So we are not an online based you know organization, and so like many organizations, we were sort of doing a lot of this like on the fly. So we used a Padlet, a series of Padlet programs, and linked them all together. So it's kind of clunky to navigate. Actually, I tried to make a video to show how to make it, and that video was clunky. So I'm just like, hopefully, you know, you know, if you click it, you click and go through, and so, but hopefully it's serving the purpose. So
yeah.
So the last thing, I guess, and I don't want to take up too much of your time, but like what's the best thing that you have gotten, or that you can tell people, like if someone is asking about this, how this can help us today?
Yeah, you know, I tell people, and I've gotten lots of, you know, as you might imagine, since the start of from the outbreak to epidemic to pandemic, we've, you know, at the center, we've gotten hundreds and hundreds of media requests, and I've been interviewed by countless reporters, and they all ask something very similar. And what I tell people is, you know, we've been through this before. Yes, there's always been and will always be pushback to public health orders, you know, whether it's a pandemic or not. We're never going to get 100% compliance, but it's important that we try and get as close as possible to that. And that, you know, these edicts, whether they're, you know, mask recommendations or orders, social distancing, you know, they're important. This is not just politicians or public health officers trying to infringe on your civil liberties for, I don't know what end, but that seems to be the comment. Oh, they're infringing on my civil liberties. It's important that we, you know, we come together as a society. And that's not just rhetoric. This is a crowd disease. It is a group disease. It is something that none of us have immunity to, unless you've gotten sick, and we're not even sure how much immunity you have from that. So, you know, it's really incumbent upon everyone to take it seriously, to do the things that we know work now. We've looked at the 1918 data. That's the largest, single most deadly pandemic in world history.
Yeah.
It's also the one that we have the best documentation for. You know, we have all this historical data that we didn't have for previous pandemics. That's why we chose 1918 to do this study. That's why the CDC was interested in that. And we know from that study that these things work. We know from now COVID, 6 months into it, we know that they work. We know that there are direct associations and, in fact, correlations between social distancing and watching the decline in cases and deaths. But, you know, we need to stay the course. The other thing that I try and tell people is that we also saw the problems in 1918 of when communities who were not through with their epidemics lifted those measures too soon. They all faced another spike of cases when they weren't through with their epidemics. And it was incredibly difficult. We only found, there may have been others, but we only found 2 cities that were able to implement the same level of closure orders and public gathering bans that they implemented the first time, a second time when necessary. It was almost impossible to do that. Like I said before, they would close schools typically, but they wouldn't issue gathering bans or closure orders of businesses because it was too difficult at that point. So they took the lid off the pot, and people didn't want to go back to the older ways that they had just come out of. Plus, it's the end of the war now, typically by November 11th. So if these things are being lifted after November 11th, that sense of patriotic duty and nationalism is starting to dwindle. People are tired of the wartime restrictions, so they want to return to a sense of normalcy. And we saw that today, even though it's not wartime. As soon as states started lifting these closure orders, even though they said, here in Michigan, for example, be careful, we're lifting them slowly, there was just a mass rush of people going back to what they thought, okay, it's over, the coast is clear, and it's not the case. And so we've seen now these new spikes of cases. We saw it in Florida and in the Carolinas and Texas and California. Now those are starting to dip, but we see them now popping up in places like Iowa. And that's the real concern, is that when it starts to hit more rural states and rural communities in states that don't have the healthcare infrastructure, that's the real concern. When you have a county that only has a couple of ventilators, and doesn't have the healthcare capacity, and you have lots of people getting sick, that's a huge problem. Plus, we already know that rural areas have been, facing a decimation of their healthcare infrastructure over the past couple of decades anyway, due to various, market forces, et cetera. So that's a recipe for disaster if we don't take this seriously going into the fall.
Yeah. So, totally. And that's sort of the way I always approach history, is like, I never sign off on the adage like history repeats itself, but there are definitely things that have happened that you can compare and get context to. And I think, like you said, with this, the 1918 one, not only was it so big and so impactful, it was obviously really unique as well. Like the role that the war plays is compounds things in a lot of ways, but just the basic day-to-day life impact I thought was really fascinating, with the similarities just on the day-to-day level between what we're going through today and what they were going through in 1918. I think that's what, at least for me, jumped out the most, looking through all this stuff. So
yeah, and the sense of uncertainty, and the fear that people have, that it's something you can't readily protect yourself from, because you can't see it. So you can take these measures, you can wear a mask, you can stay away from crowds, but you can't see it coming at you. And so that creates a lot of fear. And you also don't know when it's going to be over.
Yeah.
And in 1918, people were told that it would be over in a matter of weeks. It lasted a little bit longer. Depending on how you count it, it lasted 2 years. But the worst of it was over, within a few months in most communities. But influenza is very different than SARS-CoV-2 virus. And, get into thresholds for herd immunity, et cetera. It's about twice as high, that threshold for SARS-CoV. So, this virus, short of a vaccine, and a highly effective vaccine, and then getting enough doses into people to get herd immunity, we're going to have, this virus will be with us. I don't think that we're going to eradicate COVID. This is going to turn into, I think a seasonal disease, much like influenza. We have vaccines against influenza, and we can sort of protect against it. Those epidemic strains tend to attenuate over time and become less deadly. So hopefully that happens with the SARS-CoV-2 virus. But for now, we need, until we get more data and see where it's headed, we need to take it very seriously.
Well, thank you for agreeing to spend some time with me talking about this stuff. So
yeah, you're welcome. Yeah, absolutely. Yeah, I'd appreciate it. Thank you, because we're always happy when we hear that people are using that work that we, now it's been out going on 8 years, just 1 month shy of 8 years. It's been online, and for the first couple of years, we'd get a trickle of a couple thousand people, maybe a couple hundred in some slower months, and then suddenly it shot up to I think 400,000 hits like 2 months ago or something. So it's good that people are using it, and that as you said before, history doesn't necessarily repeat itself, but we do have these echoes, and we can learn from history. In this case, we have two pandemics caused by two different viruses, but they're very similar. The respiratory diseases, we know how they spread in the same way. And so we know what they did in 1918. We know what worked and what didn't work in 1918. And I think, 100 years later, hopefully we can really learn from those lessons and do a much better job of controlling this pandemic as compared to 100 years ago.
Hopefully.
Yeah.
But awesome. Yeah. Thank you so much for taking the time to meet you. I'll let you go. So I will talk to you later.
Yeah. Take care and stay safe.
Yeah. See ya.
Okay. Bye.